I hope everything is fine. I'm just, I don't know what happened, but I find myself out. So the voice is clear, everything is fine. Okay, so we're talking about, yeah, that is it aggressive lesion or non-aggressive lesion, and we'll check the zone of transition. So here maybe is a bit wide zone of transition because it's not distinct that you can visualize normal medullary bone or the normal bone and the abnormal process, right? And here you can see the periosteal, but also you can see that there is something going soft tissue, and this is confirmed by MRI, right? So whenever you see this, then you are talking more about something aggressive, right? With the soft tissue. So here the surprise that is, and again, another aneurysmal bone cyst. So keep it in mind, and when you find it, you will put both. Yes, exactly. So you put both aneurysmal bone cyst and telangiectatic osteosarcoma, especially if you find some soft tissue. So don't go directly that it is, yeah. So this one, I think they will, yeah, telangiectatic osteosarcoma, especially with this soft tissue. This one, they put it aneurysmal bone cyst. Maybe they consider this one that is fluid level inside. Maybe I mistake in the, yeah, it's maybe this one is could be inside this lesion. So maybe it's not soft tissue. So in this case, you can consider it as a benign lesion. Yes. Okay. So telangiectatic osteosarcoma. Um, yeah, I think even in this case, when you find let's just share with us something here. Yes, share with you. Yes. So yes, musculoskeletal is here. So when you find the criteria is not going well, and also this like few pictures, so maybe it's not typical. But let's go to real case with multi images, and we can scroll. This patient have something subcutaneous, and it is, they say that is linked to the thoracic cage. In ultrasound, maybe you can find something here. Do you agree with me that maybe something going here? Yes. So what it could be, I think everyone will agree with me that is not enough the ultrasound here. So we are going to check what could be next, right? So they did MRI and they find this lesion, yes, in the coronal image. So if you want to describe it, how will you describe it? This is the most important. You will describe it as a bony lesion again, or in the soft tissue, including the muscle and so on, and the fat and so on, or you in the joint. So I sure that you are going to be what? It's going to be joint, or what do you think? I am trying to visualize with you. Where do you start? Do you start as a bone or soft tissue? I know that is not easy, but when you mix, try to go to the basic sequence of T1 and T2, and also to compare to the other side if it is visualized, to see it is including the bone or not. But here I can see that the fat around the lesion, I can see it clearly. Yes. So when you see this fat, and do you see any sign of aggressiveness in this lesion? No. So you are going that soft tissue because you don't see any connection with the bone. Maybe here, but you cannot distinguish it clearly, right? That is in the bone. You can see that in between, but you cannot see like clear connection with the bone, right? So mainly in the soft tissue, you agree with me? Yes. So one of the differential will be elastofibroma dorsi. Okay. What else? Before we go to the diagnosis. So what else could be? When you find like something non-aggressive growing in the soft tissue, you see it by ultrasound. It is lump. So put other differential if you can. Also check that take homogeneous enhancement here. Yeah, it can be BERSA, but the BERSA it can take marginal enhancement. So yes, so one of us, yes, say that could be hemangioma and neurofibroma. Yes, so this one was a good example of hemangioma, which is non-aggressive lesion that you just, if you say that is non-aggressive and you put differential for short equation of this case, it will be very nice. So let's have another case. I hope it can move more quicker. Yes. Yes. So again, you will ask yourself one question: is it bone? Is it joint? Is it soft tissue? Then try to make the differential based in this. So if we consider this one as a lesion, so he will ask you to put mark. So you put the mark here and you consider. Then you ask you, yes, what is the differential? And you will put the calcific tendinitis, one of the good differential, because it comes inside of the supraspinatus or the rotator muscle insertion. So you will put one of the good differential will be calcific tendinitis. Again, you can put tumoral calcinosis, but it is more than this. It comes with more appearance than this head, but you don't have any destruction or even any lytic lesion in the femora. You'll put myositis, ossificans, maybe, but also the appearance of calcification not typical, but very good differential. You put it, and finally, let's see what it could be. Yes, it is yes calcific tendinitis, which common condition and make pain and limited shoulder movement. And the supraspinatus is the most involved. They like MCQ, and calcification is common. So let's have another case. This appearance is very, very important in the exam, and they like this case much. When you see this, you think in three things, especially if he's a young. Either you check the density, as we mentioned before, that it could be a vascular necrosis, but in young patient, you can say it perthis, or check if there is any widening of the joint, if he is again young, and you can consider something like septic arthritis. But last one, which is the more difficult one, that you should check the joints exactly and check the density of the bone and check the, yes, what it could be. I am waiting, because you should make a, sometimes it can come bilateral, but in this case you are lucky because it come in one side, and you make a your checklist in X-ray always. No, it's not perthis. It's not perthis. Okay. So you check your checklist. So look in the epiphyseal part here. Is it similar to the epiphyseal part here or not? If you say not, so what it could be going here, is it this is the abnormal lesion here? Yes, this is the abnormal lesion here. So what it could be, if this here is patient is young and you see this small epiphysis, so check the alignment of the epiphysis with the metaphysis. Is it in the same alignment or not? Yes, so it could be exactly. Here he will ask you to draw these lines, which is the important lines when you check any hip of the Yes, so this is slipped capital femoral epiphysis. Perfect, Dr. Karim. So this more easier if he show you this frog leg view, which is more, yes, this lines, clean line, yes. So if you check these lines and you find this appearance, this patient underwent this operation later on to correct the scaphy or the slipped capital femoral epiphysis, and you can see the difference between this appearance and sure that very important to know that if it's slipped the capital femoral epiphysis, and you should know, aware about the lines to check them correctly, and when you draw line from here you should intersect a part of the epiphysis to be after this line. So for example, if you draw the line here, yes, there is one of this will be, yes, here, but here you cannot see anything, right? So this means also you can check the one of the good key, the size of the epiphysis and also the direction of epiphysis. If it is going down, so you are going with slipped capital femoral epiphysis. I think this one it will be easier now because already we mentioned differential diagnosis and we mentioned something. Let's be quicker. Anyone tell me exact? Yes, Paget, yes. So let's go to the next. So this one is one of the tricky cases that you will ask yourself our regular question, is it bone or joint or soft tissue disease, which is mainly like maybe some diseases can take everything, but what is more affected here? I think you are going to tell me that the bone density here is decreased, more here and more here, and you can say that the tarsal bones is affected, right? So the density of the tarsal bone is affected is not less frank, because if you check the alignment here, the alignment is very good. So it's not less frank, because if you check with me the alignment, you'll find that alignment going very well. So yes, I agree with you that it is very articular osteopenia. So when you find like this osteopenia, so what is your differential? Yes, exactly. So you can think about something neuropathic, and if you want to have like case scenario, exactly, you will ask about any operation before. If this patient underwent operation and he have some of this use, he will present to you with this type of disease, which is called complex regional pain syndrome. And they like it in some exam and they consider it like antimony, but is, to be honest, is not very antimony in this appearance. But when you find this, check Sudex atrophy or sympathetic atrophy or complex regional pain syndrome. They have many names: regional pain syndrome, disuse osteopenia, whatever. But one of good differential you can put Charcot, to be honest, is not, because you will put Charcot if there is any these destruction, and there is fragments, dense debris, and. But you can say early Charcot, yes. If the early Charcot happen, yes, maybe, and also exactly the Charcot have increased density, maybe, yes. Okay, so let's go to the next one. So if he gave you one view and you are lucky to get another view, if you are not lucky, you can ask if you are in oral exam to get another view. And yes, so you have this appearance, and your question again, is it joint or bone or soft tissue? So I think everyone now is going that it could be Yes, maybe if we mention rheumatoid, so we are searching for joint more. If we say the hemochromatosis, yes, we will search for joint and some characteristics in hemochromatosis. So let's CBBD will be good differential, but you are checking for any calcification, especially in the site of the triangular fibrocartilage, right? But I think it's good differential to both. So I think in this patient with something going here, which is, I'm trying to get the other image, it's more apparent in the frontal view, yes, which is the hook osteophytes. Yeah, exactly, the hook osteophytes. So when you saw this appearance of the hook, you are going more with the hemochromatosis. You will put differential CBBD, uh, calcium pyrophosphate, and especially if you find chondrocalcinosis. Exactly this. So, okay, I'm trying to remember to put in the list to check it later on. Okay, so let's have another case, which is one of the, yeah, this diagram is helpful to go through the distribution. When you find distribution, for example, the psoriasis, it have distribution to take the dip and the pip and the interphalangeal of the thumb, okay? I think if we go, yes, for example, here the gout is very useful to just to check it. Yes, the gout. It take the metacarbophalangeal joints and the calcium pyrophosphate, which have affection of chondrocalcinosis, and it can also include the metacarbophalangeal joints, as we mentioned. So just to check. In the rheumatoid arthritis, it affects the metacarbophalangeal joint and the BIP, and again here in the intercarpal joints. Yes. In the erosive, which we mentioned it from a while, if you remember, it was taking the dip and pip and the first metacarbal joint. Yes. So this is one of the. I think I will add it also to check it when you go to the list. Let's go to another case. Yeah, I think one of the very important, the soft tissue calcification. I just want to check it because we mentioned that already CBBD included in the differential, but there is some types like this dystrophic soft tissue calcification, which is the most common types, vascular calcification. We mentioned CBBD and metastatic and idiopathic tumoral calcinosis. Someone has mentioned it also. If you find also scleroderma, this dermatomyositis, could be infection and tumoral like osteosarcoma, and if it is synovial type, also synovial osteochondromatosis, sorry, and myositis, ossificanis. So one of the important differential that to know the soft tissue calcification, we mentioned it also from a while. Let's go to this case. Yes. So again, our question: joint, bone, or soft tissue. So if you agree with me that here, yes, is a bone lesion, and here will be the question: is it lytic, sclerotic, or maybe something mixed? So good differential sarcoidosis, spine ventosa, which is TB, right? So this appearance with the lace-like pattern, to be honest, is like antimony for sarcoidosis, but it's not very antimony. But take it in consideration when you find this lace-like appearance. put in differential and ask for X-ray chest or CT chest if you have to check it. If you find something like this sarcoidosis triad with bilateral lymphadenopathy, hilar lymphadenopathy, then it is sarcoidosis. But in the differential, you should put like many differential